I have made two PPTs. This is the general overview. Is it visible?
Yes, sir.
Yeah. So this
It
is the
just
general
went off.
overview of the interview of INI-SS, how it will be conducted and what pros and cons you have to take care of. Okay.
Sir, I think the PPT just went off the screen. I think you just stopped sharing it.
Just a sec.
Yeah, now it's visible.
Yeah. Is it fine or should I make it full screen?
So it's fine if you prefer this way.
Okay. Just a sec. Is it visible, right?
Yes.
Yeah. So this would be the pattern of more or less the interview. And there will be one long case, there will be one short case, one or two instruments, one or two operative procedures. There, now this is the offline interviews, right? So there will be cheat system for the instruments, operative procedures. There will be one or two radiological scans like X-ray, CT scan, 3D scans. Recent advances and ward rounds are optional. Like if the interviewer is interested, then he might ask for the recent advances and ward rounds. Okay. These are the key points which usually the interviewer judges are on your answers, like how clinical mature you are, the decision-making power on the basis of clinical cases, the communication clarity, stress handling, and surgical judgments. How surgically you are sound enough to answer in the case studies. This is the general overview of your academics till now you have appeared for. That is the MS General Surgery basics. You have to know about the specialty branches you are opting for. Like you are opting for the plastic surgery, you have to know basic concepts about the plastic surgeries and the landmark classifications, basic classifications. You have to be clear of operative steps of few procedures that would be very basic procedures, uh, basic anatomy you have to be clear about, and complications and management of the case which you have been given, the long case and short case, and what are the complications of the surgical procedures you are performing in that cases. Basic instruments you have to be very clear about, and recent advances is the credit questions. If you know, that is well and good, but if you don't know, then don't be uh, like upset that I don't know and I have not answered the question. These are the core topics of the plastic surgery which you have to go through today. Like your interview is tomorrow, so you have to just go through these topics today only. I will share the PPT so you can go through the topics. I have also given the subdivision of the topics in the later part of the PPT. In the rapid fire rounds, you have to be take care of these few things, that your answer should be very structured. It should be not like uh, you have to you are keep on going on speaking, but the examiner gets bored. So the answer should be very structured answer. Second point is it should be short and very specific, and you have to expand the answer whenever the interviewer asks you. Don't tell everything in the first go. Just give the brief of the topic, then let the interviewer ask you more questions. As much questions he asks, you go on answering the questions. Like uh, for a gynecomastia case, the format should be definition, classification, management, and complications. So you have to answer like this: gynecomastia is a benign proliferation of glandular breast tissue in males. The classification is the Simon's classification, which is commonly used. Management depends on the grade and skin excess, if it is present, ranging from liposuction to gland excision with skin reduction. So this much answer is sufficient, and don't be like give the answers in monologues. It just bores the interviewer. Okay. Clinical thinking is also one part which the interviewer judges you uh, on the basis of clinical thinking. Like, for example, instead of saying this, the free flap is the gold standard as an answer. You have to, you can also say, like, I would choose free flap because the defect requires thin, pliable tissue with reliable vascularity and allows single stage reconstruction with better functional outcome. So this is more sound enough, and the uh, interviewer judges from this answer that you are clear enough from this answer, that why are you opting for free flap and not for the pedicle flaps. You have to also prepare this basic CV. Uh, just keep in mind that you are aware of your publications, thesis details, surgical exposure, conferences you have attended, the awards which are given to you, and complications which you have handled in the general surgery part, and your interest in the specific field, like in plastic surgery, what you are interested in. You have to just keep in mind these few points, because they might ask you about your basic curriculum. Ethical judgment is not that important, but just keep in mind and go through this part also. Like you have to be aware of your patient safety first, proper counseling, documentation, ethical transparency. These all points you have to be aware of, but it doesn't matter that much at this point. Now in communication, what do's and don'ts you have to be taken care of. Like do's, you have to sit upright, pause before answering, maintain calm eye contact, and admit when unsure. If you are unsure, don't bluff. Just admit it that I am not sure enough, sir. And don't interrupt the interviewer. Don't just bluff around. Don't speak too fast. Overviews of jargons without clarity is also irritating to the interviewer. And don't argue aggressively. If there is some debate, then just say sorry and wipe it off. For example, best answer would be, I am not completely certain, sir or ma'am, but my understanding is that blah blah blah. This would be the better communication with the interviewer. These questions also might be asked in the end of your interview, like why this specialty, what is the reason for opting plastic surgery, why you have opted for this institute, uh, what are your career goals, strength and weaknesses. Work-life balance doesn't matter much, but keep in mind just for the preparation. And ethical dilemmas also doesn't matter much, but you have to keep in mind. This is the basic preparatory strategy, like in morning, evening, afternoon, and night, how you have to prepare for it. So, but it doesn't matter much now. In mock interview, you have to first introduce yourself. Usually, interviewers, uh, you have to greet the interviewers and then introduce brief introduction of yourself, why you are opting for plastic surgery, why not other branches, uh, which difficult cases you have handled in the general surgery part, complications which you have learned during your tenure in the general surgery, what are your future plans, and why should interviewer select you. So you have to give some basic brief about these questions, and just prepare it, because this might be the questions in offline interviews. You have to also look around for this specific part of the institute, like what are the interest of the faculties, what are the strength of different colleges in INI. So please keep in mind that this part also you have to prepare. This all parts are like you have to just keep in mind. This might be asked in the interview or they won't ask, but you have to be aware about this part also. This is the final advice. Like the strong candidate usually thinks systematically. They don't haywire in the way that you say anything and examiner doesn't catches you. Stay calm. Admit limitations. If you don't know anything, then please admit it. Demonstrate the safe surgical judgments. uh, Show genuine passion for your specific field, like for the plastic surgery interviews. Usually the reconstructive part is more of us in the interviews, but you have to be mature enough to say that in reconstructive thinking should be more better rather than only theoretical knowledge, because nothing is wrong in plastic surgery. If you are able to justify your answer, then it is right in plastic surgery. Okay. These are the few questions which you can go through today. So I will share the PPT and you can look out for these questions in the text. Okay. Okay. Thank you. So should we start with the interview one by one?
Yes, sir, we can do that. And
Yeah.
also the fourth
Any
student has
doubt
also
in this?
joined.
Any doubt in this basic PPT for the three candidates?
No, sir.
Okay. Then we will start with the interview one by one. Just a second.
Sir, actually, the fourth candidate has also joined. So maybe we can just repeat one of the cases that you have made.
Okay, sure. Okay, then let's start with Dr. Manu. Okay. Dr. Manu, are you ready?
Yes, sir.
Yeah. So this is your long case for today. You can go through the case and then we can start.
Okay, sir.
Okay. So according to the long cases, these are the same as you have presented in your general surgery. Okay. So basis on this basis, you can start with your uh, history, and then you present with the examination part.
Sir, so first coming to the history, we'll ask the patient regarding the history of tobacco chewing
Okay.
and chewing uh, and Doing history of tobacco use. For how many long years he is using the tobacco, sir?
Okay.
Any history of weight loss?
Okay.
Any history of pale pain while swallowing?
Okay.
Uh, uh, okay, sir.
Okay. Like this is a dummy case, so it would be difficult for you, but you might get a live case in the interview. So you can start with the basic history and history of presenting illness. After that, what would be the negative history in this case? Like, what are the negative points you have to rule out in this point, in this case? Like in a case of oral malignancy, there is excessive salivation. So you have to rule out was there any history of any excessive salivation in the past 1.5 month? Okay. Second would be if there is any nerve compression, then it would be very painful and numbness would be there in the cheek part, according to this case. So you have to rule out that too. Any history of bleeding while chewing or during the daytime or nighttime, that you have to rule out. Okay. And any dental caries you have to rule out.
Okay, sir.
Okay. Now looking at the photograph, can you give the examination part?
Sir,
Yeah.
around 4 into 3 centimeter growth present in the left buccal mucosa,
Okay.
which is which is sir, trismus is absent in this case.
Okay.
Yes, on bimanual palpation, growth in the
Actually, the photograph is from the inside only. So the lesion is not on the exterior of the skin.
Okay,
So
sir.
you can mention that too. You can take any landmarks like the lesion is extending from 2 centimeter above the lower buccal gingival sulcus to approx 1 centimeter below the upper GBS, and from left angle of mouth on the uh, uh, from the left angle of mouth to the approx 4 centimeter. No, it's just above the second molar.
Okay, sir.
So you can mention from the bony landmarks that what is the extent of the lesion, and you have to mention about the ulcer or proliferative lesion. So either the ulcer is bleeding or not, how is the bed of the ulcer? That are basic general surgery questions. Okay. So how you are presenting in general surgery, you have to present it like that only. Okay.
Okay, sir.
Now moving on to the viva. What would be the diagnosis of this case?
Sir, sir, first we'll look for the first we'll do the investigations of this patient, sir. We'll go for all the
No, you have to first give the diagnosis and then let the interviewer ask you the investigation or management part.
Sir, this is looking like squamous cell carcinoma, sir.
Okay, so while giving the diagnosis, you have to give a brief history also. Like a 52-year-old male patient presented with ulceroproliferative growth over the left buccal mucosa since 5 months, with the complaint of pain, difficulty, and weight loss, and he has history of tobacco chewing. uh, Most my provisional diagnosis would be left buccal mucosa carcinoma. So you have to just elaborate your provisional diagnosis.
Okay,
Okay.
sir.
Say like provisional diagnosis only because you have not confirmed on biopsy. So it would be provisional for you. Okay. Uh, Now, after diagnosis, how will you proceed with this case?
Sir, first coming to the investigation, we'll do all the routine blood investigations, sir, like a
Okay.
complete count, serum, liver, LFT, RFT, serum albumin, total serum albumin. Then we'll go for the radiological investigations like orthopantogram. Then we'll go for CT neck from the base of the skull to the neck.
Okay. Okay. In this, you don't have to elaborate all the blood investigations. It was a part of general surgery. Now, in super specialty branches, you have to just say, I will do routine blood investigations for the operative purpose. So that will suffice your answer. And for CT, you have to go for CT face along with neck.
Okay, sir.
Okay. You can also say CCT. Okay.
Okay, sir. Okay.
And then,
Then, sir, after the biopsy report, then we can plan for the surgery, sir.
which biopsy will you do in this case?
Sir, we can go for a shave biopsy, sir. Excisional biopsy.
Okay. No. Excisional biopsy. Excisional biopsy is a part of like small cancers where the lesion is very small and you can take the margin along with the uh, cancerous part. Okay. So excisional biopsy won't be enough.
Shave
Uh,
biopsy.
yeah, you can go for a punch biopsy in this case. Okay. So keep in mind that types of biopsy might be asked in the interview. Okay.
Okay, sir.
Like when will you take wedge biopsy? When will you take excisional biopsy? When will you take incisional biopsy? Okay.
Yes, sir.
Okay. Now you have confirmed your case on investigations by biopsy. So what would be your management part?
Sir, we'll look, sir, come to the management. Sir, as it is a squamous cell carcinoma, we look for the depth of, if the lesion is more than 2 centimeter, then if it is less than 2 centimeter, we'll go for 0.4 mm clearance, sir. If it is more than 2 centimeter, we'll go for 1 centimeter clearance.
Okay.
Clearance, centimeter clearance, and clearance. Sir, we have to tell the surgery also, sir.
Yeah. So that part will be taken care of by the surgical oncologist.
Okay, sir.
And after excising the primary lesion along with the neck dissection, the defect which will be presented to us, we will go for the reconstructive procedure on the basis of the defect size.
Yes, sir.
You could be specific in this part because this part is done by the surgical oncologist.
Okay,
Okay. So you can answer it in that way also.
Okay, sir.
What would be your plan on the basis of defect?
Sir, in this we can go for DP flap or the PMMC flap, sir.
No, DP flap would be difficult in this case because usually we go for DP flap in cases where there is a external defect also.
Okay, sir.
Okay. PMMC is one option. Okay.
PMMC, we can go for radial forearm flap or anterior lateral thigh flap.
Okay.
Um,
Primary option PMMC or radial forearm or ALT flap.
okay, sir. These three flaps we can go, sir.
No, what would be your first option?
So first is always PMMC flap, sir.
Why?
Sir, because it is a type 5 flap.
Okay.
And it has one dominant and segmental pedicles.
Okay.
And
but it will give more bulk to this patient. PMMC flap would give a more bulk to this patient, and I might not go with PMMC flap. Why?
sir, can go for so we can try radial forearm flap, sir. If bulk is the issue, then we can go for radial forearm flap.
If, for example, this would be a 25-year-old male patient,
Yes, sir.
then will you go with radial forearm?
No, sir.
Why?
Because of the cosmetic deformity, we won't go for radial
Yeah, cosmetic and functional deformity.
deformity.
Yeah. So in that case, what would be your primary goal?
So we can go for anterior lateral thigh flap.
Yeah, you can go for ALT flap.
ALT flap.
You have to be also aware about the reconstructive ladder.
Yes, sir.
Okay. PMMC is always an option.
Yes, sir.
Okay. Okay, so you have to be aware about the anatomy of the flap.
Yes, sir.
How you will harvest the flap.
Yes, sir.
Then what are the precautions you have to be taken care of while harvesting the flap, and what are the complications of the flap. Okay. Like if you are going for PMMC, ALT, or radial free for radial flap, then you have to also examine that part. So you have to tell the interviewer that I will examine the chest, forearm, and thighs. Okay. What are the precautionary measures which you will take in examination if you are planning for radial flap or ALT flap?
Sir, first we'll ask about the smoking history of the patient, sir, and we'll get urine nicotine test done, and we'll tell the patient to stop smoking 6 weeks before the surgery.
Yeah. Okay.
Then we'll get a UHD Doppler to know the patency of the vessel, sir.
Okay. What would be the clinical test you will go for radial flap?
Sir, we'll go for Allen test, sir.
Okay. Okay. Good. Okay. And you will do the surgical marking along with the Doppler. Okay. Handheld Doppler. You will look for the perforators with the handheld Doppler. Okay. So more or less this would be the pattern in long case. Okay. Like it's not your final plastic surgery exam, so they won't go that deep, but you have to be aware of this much part.
Yes,
okay. Now let's move on to the short case. So this is your short case.
Sir, this is a case of
Yeah,
left.
in short case, you can go directly with the diagnosis.
Okay, sir. Sir, this is a case of left-sided complete cleft lip and right-sided incomplete cleft lip with Simron's band.
Mm, I don't appreciate anything on the right side. It's just a left side with medial outturn. Okay.
Okay, sir.
Uh, so left side complete cleft
Inc-
lip
okay,
along with nasal deformity
sir.
and Simon's band. Just a second. No, there is no Simon's band in this case. It is complete only.
Okay, sir.
Okay.
Yes, sir.
Like alveolus is not uh, properly appreciated in this photograph, so we cannot comment on that.
Okay, sir.
But what would be your classification, and which classification do you follow?
Sir, for we can, sir, Nagpur classification we can follow, sir.
Good, good.
According to Nagpur classification, this comes under uh, 1S, sir. One. It comes under 1A, sir.
Okay,
Then,
okay. Yeah, alveolus we don't know, so we are
okay.
not commenting on that. Okay. And you have to be aware of other classifications too.
Oh, sir. There is VOS classification,
Yeah.
LAH-SHAL classification, and
Yeah. So you have to be aware of that Karhan's classification, and there are many classifications in cleft lip and palate. So you
Okay.
have to be just aware of that part.
Okay,
Okay.
sir.
But in India, we follow Nagpur classification most of the time.
Okay, sir.
What is rule of 10?
Sir, according to the rule of 10, the patient should be 10 pounds of weight, 10 weeks of birth, and he should have hemoglobin of 10 milligram per deciliter.
Okay. These are the three basic rule of 10.
Okay, sir.
Some examiners might ask about the WBC count. So if they ask, just tell them it should be less than 10,000.
Okay, sir.
Okay. What should be the timing of surgery in this case?
Sir, in this we can go for around 3 months, sir.
Okay. So the patient is presented to us at 6 months.
Yes, sir.
So can we do the surgery at that time?
Yes, sir. We can go for cleft lip followed by cleft palate around 9 months, sir.
Okay. Okay, good. And what should be the timing for nasal deformity?
Sir, nasal deformity, it should be around primary, sir, around 5 to 7 years of age, sir.
4 to
Primary
5 years of age. That is
4 to 5 years.
preschool age.
School age.
Before the patient goes to school, so we can correct it. Okay. What would be the surgical plan?
Sir, in this patient, we can go for modified Millard's technique, sir.
Okay. What other techniques do you know?
Sir, there is Fisher technique, the latest technique, and there is a Thompson technique, sir, and Thompson, and there is Ranson
Yeah.
technique, sir.
Tennyson-Randall technique. Yeah, that is more specific and geometrical technique. Okay. Among the Millards and Tennyson-Randall, if you have to revise the case, like there is a short philtrum, there is uh, contraction band, then which would be better, Millards or Tennyson Randall?
So Tennyson would be better, sir.
Revision cases, if you are a fresher and you are not sure enough, then go for a Millard's technique.
Sir.
Okay,
Yes, sir.
that is more better technique if you want, if you are not sure and if you want to revise it later on. Okay.
Okay, sir.
For what is the advantage in Tennyson Randall
Randall.
or disadvantage of Millards?
Sir, in Millards, we there is a back cut, sir, in the columella, and there is a C-shaped flap from the philtrum that we take, and it is a rotation advancement flap.
Okay, very good. But why Tennyson Randall is better than Millards? In
Sir.
which term Tennyson Randall is better than Millards?
Sir, because of the straight line closure.
Yeah. In
Straight line
Millards,
closure.
there is a straight line closure.
Yes, sir.
So chances of contraction are there. No, sorry, contracture is there in future. Okay. What would be the post care for this patient?
Care for the patient. Sir, sir, we can give pigeon nipple bottles, sir, for feeding.
Okay.
No, sir, I'm not certain of this.
Yeah. So what would be your feeding advice after surgery?
Sir, sir, there is a method. There's a specialized bottle, sir, for this pigeon nipple bottle and Hauser bottle, and that
Yeah.
and the patient should be in prone. We should tell the mother that feeding should be every it should be small, frequent
Yeah.
type of.
Yeah, exactly. Small feeds, frequent feeds, and you have to maintain some basic posture of the baby.
So the patient should be in 45-degree position.
Exactly. Yeah, exactly. And you can feed with a spoon also.
Okay.
Okay. Just you have to take care that you have to not injure the suture line. Okay. Yeah, this is fair enough for this case. Okay. Let's move on to the instrument. Can
Sir,
you identify this instrument?
Sir, this is Watson's modified Ambis knife, sir.
Okay, good. What was the modification done in Watson's modification?
Sir, in the rectangular frame, sir, the outer uppermost the circular I'm not able to recall, sir. Sir, the adjustment is no.
There is a adjustment roller over here.
Yes, sir.
Okay, so the surgeon can easily glide the skin. Okay, so that was a modification, and it was adjustable.
Adjustable. Yes, sir.
It with the roller. Okay, so this was the modification. Is this right-handed or left-handed, or any surgeon can use this?
Sir, this is right-handed, sir.
Okay, yeah, this is a right-handed. So in grafting handles, you have to hold the handle like in a live interview. you have to hold the handle in right or left hand according to the handles. Like if it is right-handed, you have to hold it in right hand, and if it is left-handed, you have to hold it in left hand. Okay. What are the other uses of this instrument?
Sir, it can be used for tangential excision also, sir.
Yeah, good. Definitely. Tangential excision, derma abrasion. Okay. So it can be used for that too. Handles also.
Yes, sir.
So they will ask you modifications and other type of handles. Okay. And what would be the sterilization technique for this instrument?
No, sir, I'm not certain of this.
Autoclave. Okay. Now let's move on to the operative procedure.
Yes, sir.
Diagnosis of this.
Sir, this is a case of incomplete syndactyly of the third and fourth finger, sir.
Okay. Good. What would be these operative steps?
Steps. Sir, first the goals of the reconstruction, sir.
Okay.
Sir, we want to separate the buds and separate the soft tissue as well as the bone.
Okay.
Second goal is to preserve the neurovascular bundles and the blood vessels.
Okay.
Third is to provide function and aesthetic outcome of the procedure.
Okay. So in live, like in this interview, we cannot go for marking, but
Yes.
in live interview, the interviewer will ask for the marking also.
Okay,
So
sir.
you have to be aware of the markings in this case. Okay. Like which flap will you raise for the web space?
Okay, sir.
And you have to be also aware of the timing for this surgery. If
Yes,
this is a 6-month-old baby, then can we proceed with the surgery?
Sir, we have to look for broad digits and this one, sir. Broad digits, it's around 3 to 6 months. In this patient, we go for 9 months, 9 to
Okay.
12 months.
Yeah. Okay. Good. So you have to be aware of that part too. Okay. Describe this.
Sir, this is an orthopentagram showing fracture of the uh, 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 fracture of the mental part of the mandible, sir.
Symphyseal part of the
The
mandible.
symphyseal part of the mandible.
Yeah. Okay. So what would be your management?
Uh, uh, Sir, sir, we can go for open reduction and internal fixation using mini screw plates, sir.
Okay. How many plates?
So 2 plates will put, sir.
Okay. Okay. And what would be your approach of incision?
Sir, we can go for intraoral incision, sir.
Yeah. Good.
Intraoral and
What are the other approaches?
intraoral and submental.
Yeah. Submental approach. You can also go with submental approach. Okay. So this is the basic part of the inter.
Okay, sir.
Dr. Manu.
Yes, sir.
So if you are able to answer this much, then it's good enough.
Okay, sir. Sir, they'll ask regarding facial no palsy, sir.
would
Hello, sir. Sir,
Yeah.
regarding patient of palsy, they last, sir, in interview.
Sir, you're not audible if you are speaking.
Hello, sir. Hello.
Yeah, Dr. Manu, you're audible. Dr.
Sir,
Dev, sir, is not
regarding patient of palsy, they last, sir, in the interview.
No, I think sir is speaking, but he's not audible. So
Okay.
there might be some internet connection issue or something.
Okay, sir.
Sir, if it's still not working, maybe you can try rejoining the meeting. Hello.
hello.
Hi, sir.
Yeah, am I
Yes, sir.
audible now?
Yes, sir. you're
Yeah, there was some internet issue. They might ask about facial palsy,
Yes, sir.
but it's like if you are able to answer, that is good. But
Okay.
if you are not, then they won't cut your marks. Okay.
Okay. Sir, regarding aesthetic surgery, sir, what questions they might ask, sir?
I have given the list of questions in the aesthetic part. I
Okay.
will share the PPT in the group,
Okay.
or I
Okay.
will provide it to the Dr. Alesh. He will send you the PPT. Okay.
Okay, sir.
So I have mentioned in general part what you have to go through, in hand surgery what you have to go through, in burns and in aesthetic also.
Okay,
Okay.
sir. Yes, sir.
Uh, any other question from you, Dr. Manu?
Okay. No, sir. Thank you, sir.
Okay. All the best. So let's start with Dr. Lakshmi. Yeah. So this is your case, long case. You can go through the case and then start with the history of presenting illness and examination.
Yes. Hello.
Hello. Yeah, you can start with your presenting illness and examination.
So this is a 30-year-old female who was presented with a history of plain burns
Okay.
6 months ago. And she has underwent treatment initially with regular dressings. as
Okay.
mentioned. And now currently there is a difficulty of extending of the neck with difficulty in upward gaze,
Okay.
and she has issues with the cosmetic and there is cosmetic disfigurement,
Okay.
and also there is tightness of the neck. With the, as mentioned, with no history of difficulty in breathing or any ulcerations.
Okay. Okay. So what points you have to ask this patient in history? Like other than these points, what specific points you will ask the patient?
Was she offered any reconstructive procedures and why?
Yeah. Okay. Mm,
And did
And
she like post-op physiotherapy would have been suggested, but did she follow that?
yeah, exactly. Yeah, that is one point. And uh, like it's already written, she underwent dressing treatment, and you have to ask the patient for the duration of dressing. So you can judge from that part, like what would be the degree of burns in that case. Okay.
Yes.
So on the basis of degree of burns, you can judge for the contracture. Okay. So you can go on with the local examination.
Sir, I'm not sure about this case. I've never exposed me to this extent. So,
Okay. So in this type of cases, uh, on local examination, you have to just mention about the wound, like what is the extent of the wound. For example, in this case, it would be like around uh, 5, 10 by 12 centimeter of scar tissue over the neck part, extending from the mentum to the sternum. Okay, in the middle part, and in the lateral parts, it's extending from the angle of mandible to approx 2 centimeter above the clavicular border, mid clavicular border. You have to mention about the hypertrophic part, like there is hypertrophic band over the uh, right angle of mandible to approx 2 centimeter medial to the mid clavicular part. Okay, and the scar tissue looks something arithmetic. Okay.
yes.
So you have to mention, and you have to mention the range of movement in this case. Like in live case, you will be able to judge with the movements once the patient is, how much is the flexion, how much is the degree of extension, how much is the degree of lateral rotations. Okay, so that you have to uh, judge on that part. Okay, so this would be a brief of local examination. uh, Now, moving on to the diagnosis, can you give your diagnosis on this case?
It's a post-burn contracture of the neck uh, with visible scarring.
Okay. Post-burn contracture, post-burn contracture of the neck with hypertrophic bands in the right lateral part. Okay. So this would be a diagnosis. What is the classification? So you have to go through the classification in this case too. On brief note, for the long cases, you will get post-bun contracture neck, post-bun contracture axilla, uh, onco reconstruction cases, head and neck carcinoma, and leg defects. So these are the major long cases which you will be given. Okay. What would be your management in this case?
Release of the hypertrophic bands.
Okay. How will you release this band?
Z-plasty point of view.
No, Z-plasty won't give you that much extension. So in the maximum extended position, you have to tell your assistant to press over the mental part and extend the neck as much as possible. Okay. And in that position, you have to give incision, transverse incision over the maximum tension line. Okay. And in the ends, you have to give a fishtailing incisions. So that will extend the neck completely. And what would be the end point of dissection? What is your end point of dissection? Like,
Then
yeah,
where the, like usually it will be fibrous after the extent of fibrous.
yeah. Once we have incised the fibrous part, uh, the fat, the subcutaneous fat will pop out. Okay. So that is your goal of dissection. Okay. How will you cover the defect?
Full thickness in the
Mm, full thickness skin graft, it would be very huge defect in this. So full thickness skin graft would be, you have limited donor sites for full thickness skin graft. Okay. So you can answer thick split thickness skin graft. Okay. And what would be the placement of graft? I know you have not gone through this case, you don't have exposure. So you can just note down the points which might be asked to you. What would be the placement of the graft? Okay. Uh, what precautions do you take while placing the graft? Steps of skin grafting. Why not flap and why skin graft? Okay.
because the vascularity is not
No, in neck, skin flap would be too bulky for this patient. Okay. So skin graft would give you more better coverage and better contour. Okay. What post-operative care will you take in this patient?
proper dressing
Okay.
and post-op physiotherapy is also movements. And is there any restriction?
Physiotherapy is must, but that is after the graft has completely healed. Okay. For the immediate post-operative care, you have to give neck extension. Okay. So you have to give hard collar to keep the neck in extended position. Okay. So let's move on to short case. So this is your short case. You can start with the diagnosis and
So this is a case of bilateral hypomastia.
okay,
The history of more than 3 years.
okay.
So
So what is the classification?
it appears to be of moderate size according to Simon's.
So according to Simon's classification, what is the number of classification?
The 2, mild, moderate, and severe.
Yeah.
Whether fibrosis is present or it's glandular.
Yeah. The gland is visible, so it's 2B. Okay. There is mild redundancy of skin also, so it's 2B. What would be your management?
It is right. Based on the tissue type, whether it's liposuction,
Okay. Liposuction and
whether it's also ultrasound guided or radial treatments.
sorry.
Ultrasound guided.
Yeah, liposuction is one part, and along with liposuction, what you have to do? Gland removal. Along with liposuction, you have to also remove the gland also. Okay. What incision will you prefer in this case?
So,
Subareolar.
so
Subareolar incision at 5 to 7 o'clock position. Okay. What other incisions are you aware of? Inframammary incision is also there. Axillary incision is also there. Okay. Do you want to go with any investigation before operating?
I'm not able to
Do you want to go with any investigation before operating?
I'm not able to.
Am I audible?
Yes, sir.
So you can go with bilateral sonomammography and basic hormonal blood investigations. Okay. Are you aware of this instrument, Dr.
Yes.
Lakshmi? Yeah.
This is Stigma's retractor.
Yeah, good. Can you describe the parts?
it will have an alveolar bar.
Yeah.
The two retractors for the cheek.
Yeah. Good.
It has a tongue retractor also,
Yeah. Tongue blade.
a tongue blade.
Yeah.
Which will have an adjustment. So
Yeah.
we can adjust according to the size. And it will make it feasible for the surgeon to work with two hands.
Yes. Good.
The
Uh,
alveolar part will have two sockets.
yeah. And is this spring visible? Just a second. Can you appreciate a spring over here?
Okay, so yes, sir.
Yeah. So what is the use of that spring?
What?
So yeah.
I'm sorry, sir. I don't know.
It is used for holding the suture. Okay. So can you tell in which cases we use this instrument?
Left palate surgery.
Yeah, cleft palate surgery. Okay. So in live case, the interviewer will ask you to adjust the tongue blade. Okay. So how you will insert the tongue blade and how we will hold the instrument. Okay. So that you have to take care of. Mm, can you describe this surgery?
This appears to be like a fingertip amputation, where
Yeah.
the marking is done polarly. It appears to be a viva flap of the sort.
Yeah, VY flap. Okay. Are you aware of different types of VY flaps?
Lateral viva flaps.
Yeah.
Adversary is olar flap.
Yeah.
And is Venkateswamy flap also a viva flap?
Yeah. And uh, can you describe the operative steps for this VY flap?
We'll give incision along the marking, sir, and then
Okay.
we'll advance it forward till the subcutaneous layer, and we'll advance it forward over the defect.
Okay. Okay. Can you describe this radiograph?
It's a 3D reconstruction view of skull
Mhm.
with
A face. It's 3D reconstruction of the face.
a place with fracture line extending from intraorbital ring till extending down along the intraorbital foramen
Okay.
towards the maxilla.
Okay. Okay. That is good enough. How will you manage this case? Okay. No problem. That I will answer it later on. Once I will ask Dr. Nagarjuna also because I have only 3 cases, so I will give him this case also. So once he answers, I will give you the final answer. Okay. Uh, so this is good enough. Okay. Don't get scared because like you don't have exposure of these cases, so it's fair enough that you don't know about these cases, but just go through these cases once. Okay. For the major cases, I have given the list that it would be onco reconstruction, contracture neck, contracture axilla, and uh, leg defects. Okay. So just go through this once. And for short cases, it would be cleft cases, uh, contracture hand cases, dupuytren's contracture, uh, like gynecomastia case. Okay. So this would be basic short cases. Okay.
Yes. Thank you.
Okay. All the best, Dr. Lakshmi. Uh, so let's move on to Dr. Rakesh.
Yes.
So this is your long case. Yeah, you can go through and you can start with your local examination.
So this is a case of post-traumatic 40-year male patient with
Uh,
right leg distal.
Sorry, can
Hello.
you speak a bit louder?
So this is a case of 40-year male patient with distal trauma to the right lower leg with fracture of the distal lower third of right leg.
Okay.
So post-traumatic non-healing wound and is underwent external fixation.
Okay.
And there is also exposed bone and the discharge from the bone, and the patient who cannot walk for the difficult in weight bearing.
Yeah. So what would be your diagnosis?
So my diagnosis would be post-traumatic infected right distal third uh, leg fracture.
Yeah.
Tibia
So
fracture.
in examination, you have to mention the extent of the wound. Okay. Size of the wound, bed of the wound, the bone is exposed, comminuted fracture is present. Okay. And any neurovascular injury is present or not. Okay. Now, so are you aware of the classification in this case?
Yes, so there is a classification which involves low energy, moderate energy, high energy, and grade 4 is also high energy.
Yeah.
So depending on the energy type and the extent of tissue involved.
Okay.
First
So
is 1 is less than 2 centimeter laceration, 2 is more than 2 centimeter laceration.
okay. So how will you proceed with the management in this case?
For the management part, according to the complaints, first we will debride the bone,
Okay, good.
and then as the bone is exposed, so we do need first we will do fix the bone,
Okay.
and if the bone is severely comminuted, we can use tubular graft,
Okay.
depending on the type of fracture. If it is a linear or and uh, if it is simple linear fracture, we can use
So in
pressure
this
tense flap
case,
or micro flap.
yeah. So in this case, the orthopedician has already used the external fixators. Okay.
Okay.
Uh, so for external fixation, what will you take care of before using the external fixator. So will you discuss it with the orthopedic surgeon? Any points you would like to discuss with orthopedic surgeon?
Uh,
Will the part of intervention of the orthopedic surgeon matter to you, or you will just tell them that you proceed with your plan and then we will decide the reconstructive plan?
no, sir. We will make sure that the local tissue is available as much as possible and the local
Okay.
vasculature is not hampered. So we
Okay.
can use the soleal flap and perforative.
Yeah. So on the basis of your reconstructive plan, you have to discuss it with the orthopedic surgeon for the placement of the pins. Okay. So it doesn't come in the territory of your reconstruction if possible. Okay. So you can discuss it with the orthopedic surgeon and then you can proceed with the external fixator. So what would be a reconstructive plan in this case?
So in this case, we can go for reverse urinary artery perforator flap,
Okay, good.
and second is we can use soleal muscle flap available,
Mm,
and
less likely. Soleus flap.
we can
Good.
use three flap, which is LT flap.
Yeah, yeah, you can use that too. Okay. Uh, will you give the wound coverage in the first sitting only? Looking at the wound.
So wound, so initially, if so, the best result will be according to Godino principle. Within 72 hours, if we can cover the bone, cover the gap, it
Okay.
gives the best result.
Okay, good. Yeah, that is ideal. But in clinical practice, you have to first debride the uh, wound, and
Yes, sir.
depending on the infective part, you can use negative pressure wound therapy for a week, and then you can proceed with the reconstruction. Okay.
Yes.
So you have to be aware of reverse sural artery flap, markings of reverse sural artery flap. Okay. And how will you raise the flap? Uh, do you know anything about delay of the flap?
So in delay phenomena, we can increase the vascularity of the flap. We can just divide the proximal blood supply, and we can ligate the proximal blood supply. Then it will, depending on it will be blood supply will be based on the
Okay. Yeah. Good. Good.
pivot point, and it will increase vascularity.
Yeah. Good. So they might ask you for delay also in this case because the wound is large enough for reverse sural artery flap. Okay. So you have to take care of that part too. Okay.
Yes.
So let's move on to short case. Yeah. You can start with the diagnosis and and management part.
So this is a case of a 65-year male patient with an ulcer over the medial canthus,
Okay.
and which is slowly growing in size and with bleeding and testing. And on local examination, it can be seen as a beaded appearance of the margins, and
Okay.
telangiectasia visible. So most likely it is basal cell carcinoma
Yeah. Good. Good.
overlying the medial canthus of the eye.
Okay. So, what would be your management plan, like investigation and management?
So in case of investigation, we can do shave biopsy or
No,
wedge excision.
excision, because it is already small uh, lesion.
Okay,
So
excisional biopsy we can do, but in that we have to take care of it. As it is near the eye, so most micrography surgery will be better.
yeah, and what would be the margin of excision?
1 centimeter, but when you can 1 centimeter ideally.
Yeah. Do you know any recent advances for basal cell carcinoma surgery to excessively avoid the extent of dissection or extent of excision?
So I know only about most micrography surgery.
Yeah, exactly. So you have to be aware of most. And what would be the reconstructive plan in this case?
As it can be seen that it is involving less than 1/4 of lower eyelid, so it can be, but after dissection it will. So we have to need the pentagon type closure of.
Uh, for this, you can go with a bilobed uh, flap, or you can go with cervicofacial flap.
Okay.
Okay, so that will give more better results. Okay.
Yes.
Mm, do you know why it is called rodent ulcer?
Because it externally it is not visible much, but inside it can erode as deep as the bone without giving the external feature.
Yeah. So lateral extensions are less, but depth is more.
Yeah.
Okay. And what are the risk factors for PCC?
So risk factors are sunlight exposure,
Yeah.
and, sunlight radiation, smoking.
Yeah. Mainly it's sunlight exposure. Okay. So let's move on to the instrument. Can you identify this instrument?
So this is nose elevator for open rhinoplasty.
Yeah. But name of the instrument?
And then, Williamson.
No.
Sorry.
I will answer it later on.
Okay.
Dr. Nagarjuna will answer this question. Okay. Uh, can you describe this for operative?
So this is a case of complete cleft palate bilateral,
Yeah.
uh, involving the soft palate, hard palate till the envelope.
Okay.
So in this case, so we can do bone lengthen back surgery or hard L procedure.
Yeah. Okay. So
Uh,
can you describe the steps if possible?
so, sir, in this we can do the periosteal release and then close them in the midline
Okay.
and let the bone heal by let the central defect heal by. We
Okay.
will do skin flap advancement.
Okay. And what about the lateral?
Mhm.
They will heal by secondary intention.
Okay. Okay. And while describing the operative procedure, you have to start with the uh, after using the Dingman's retractor, we will infiltrate the operative area. Okay. And after infiltration, we will start with the procedure. Okay.
Okay.
Do you know anything about which type of endotracheal tube for anesthesia we will use in this case?
So we can use RAE, ring elder pelvis tube,
Yeah.
or with
It is
southern
also
with
called as South Pole tube.
south pole tube.
Yeah.
We can
Yeah.
also use armored flexometallic tube.
Yeah. But usually South Pole tube are used in the clinical practice. Okay. Yeah. Good. Can you describe this radiograph?
So this is a 3D CT face showing the lateral view of the face.
Okay.
Uh, there can be seen nasal bone fracture.
Okay.
Yes, let
Okay. So, what would be your management in this case?
the initial management. We can, sir, with the help of nose bone holding forceps, we can reduce the fracture.
So, the name of the forceps is Ash forceps.
Yes,
So, with that, will you go for the or if like open reduction and internal fixation or internal reduction only?
sir, we'll go for internal reduction.
Yeah, good. We will go for internal reduction only. And what would be the timing of surgery in this case?
So after 7 to 10 days after the initial edema and the local inflammatory changes subside.
Like if you have two scenarios, patient after RTA, the patient immediately comes to you. So, will you operate it at that time?
So after RTA, we will have to check whether the patient is stable or not. First, we will stabilize and then
Okay. If the patient is hemodynamically stable, then
so I will see if the wound is open or closed.
okay,
Local.
okay.
If it is open, we can do it immediate. If it closed, then I will wait for some time for the local
No,
edema to
if
reduce.
the patient presents you on the first day only, then you can go ahead with the OT on that day also. Okay.
Okay.
If the patient presents you after 2 to 3 days and edema is more, then you have to wait for the edema to subside. Okay. Okay. It was good enough, Dr. Rakesh. Okay. Now let's move on to Dr. Nagarjuna. Yeah. Hey, Dr. Nagarjuna, can you describe this long case?
Yes, sir. This is a case of 30-year-old female
Yeah.
having a postbone neck contracture,
Okay.
6 months of age, and
Okay.
with the difficulty of extending the neck and difficulty in upward gaze movement with significant cosmetic disfigurement.
Okay.
And in history, I have to ask about the degree of the burns and percentage of the burns,
Okay.
and any previous uses of dressings.
Okay.
And
Okay. Actually, we have discussed this, so you might be knowing about few points. Okay. So, can you give me the Local examination. Can you describe the local examination?
On examination, around 10 cross 10 centimeter size of wound,
Okay.
scarring with
Yeah.
multiple bands of around 4, extending with extent of 2 major bands on the right side from angle of the body of the mandible to the up to clavicle region, and on left
Okay.
side there is a single major band extending from the uh, extending from mentum to the clavicle, and
Okay.
minor bands are also present in between the
Okay. Uh,
with the surface appearing red in color.
mm.
And
Rather than saying red in color, you can say erythematous.
okay,
Okay.
and
Mm,
with no significant pigmentation.
okay. Uh, can you describe the classification?
So I'm not aware of this.
Okay. Uh, okay. So how will you proceed with the management in this case?
Um, we had to extend the neck, and we had to do the release over the major bands
Okay.
with skin split thickness skin grafting.
Okay. So do you know anything about uh, excisional release and incisional release?
Incision release, we have to make incision over the band, and we have to cut the fibrotic band.
Okay.
Excision release, if it is small, we can excise completely.
Okay. So in this part, which part do you think we have to do excisional release and we can only go for incisional release in which part?
Incision release over the right side 2 major bands, and left side 1 major band. And
Okay.
incision release, we can proceed with the near the sternal notch. Some bands are there.
No. You can answer it like this, that in the hypertrophied part, you have to go for excisional release. Okay. And in non-hypertrophied parts, we can only go for incisional release.
Okay.
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 If uh, just to change some scenario in this case, if it would be completely like this, okay, sternomental adhesions would be there. So in that case, how will you intubate the patient? Will it be possible for the anesthetist to intubate this patient?
I'm not aware of that. So, okay.
Yeah. So in this sternomental adhesions, sometimes you have to first release the uh, contracture in local anesthesia, and then only the anesthetist will be able to intubate the patient. Okay. So this might be scenario in some cases, and then you can proceed with the surgical part later on after releasing the contracture band in local anesthesia. Okay. Uh, like looking at this case, uh, will you operate this patient at 6 months?
I'm not sure.
So basically, arrhythmia is present, and the scar has not matured that enough. For the scar maturement, it takes around 9 to 12 months. Okay. So once the scar matures, then we can proceed it with the uh, operative part or contracture release. Okay.
Okay.
We can do it in this case, but ideally we should wait for 9 to 12 months. What post-care will you advise in this patient?
Post care, we have to dress it properly with in a proper position with the slight extension of the neck, with the minimal rotation of the neck,
Okay.
and till the wound healing properly. After
Okay.
that, we can advise the physiotherapy.
Okay. So in the extended position, how will you keep the extension in wards? Like you go for ward round in the evening. So what advices will you give to the patient for neck extension?
In supine position, we can tell them to place one shoulder pad.
Yeah. You can place 1 or 2 pillows below the shoulder and 1 pillow below the head occiput. Okay. So that will give you extended position, and you can also use a hard neck collar. Okay. Okay. So let's move on to the short case. Yeah. Can you describe the short case?
This is a case of a male child, 6 months old male child with complete cleft lip on left side.
Okay. What will be the timing of surgery in this case?
As the baby is already 6 months old, we can proceed with the surgery. This is the right time for the left surgery.
Okay.
And if we, as it is only confined to cleft lip, we can proceed with the lip only.
Okay. If the alveolus is also involved, then what would be your plan of management for the alveolus?
For areolas, we have to wait until 3 to 4 years of age, and we can place autologous bone graft.
Yeah, autologous bone graft is right, but not 3 to 4 years. It's 8 to 9 years of age. Okay. Can you describe any one technique, Millard's or Tennyson Rundle?
Tennyson Randall, no sir.
Okay.
I have to
Just
say.
go through, yes, this is for all the students. Just go through the techniques of Millard's and Tennyson Rundle. Also look for some basic markings. It is not mandatory for you to mark in exam, but you have to be aware of the markings. Okay. And there is one more technique which is called Nagpur's triple wedge technique. Okay, so just go through that also, because there are 3 wedge incisions in the Nagpur technique. So you have to be aware that where we have to place the wedges. Okay. Okay. Let's move on to the instrument. Can you describe this instrument?
Sir, I'm not aware of completely because I didn't see in this instrument, but to my knowledge, it is an off reach elevator.
Yeah, exactly. Off-ridge retractor. Where it is used?
In rhinoplasty, when using the dorsal skin elevator, elevating the dorsal skin.
Yeah. So basically for the dorsal hump reduction, you have to elevate the dorsal part. So we use usually for dorsal skin elevation. Okay. What is the technique of sterilization for this instrument?
As it is a such autoclave only, sir.
Yeah. Okay. Can you describe the surgical procedure?
Multiple jet pasties we can do, sir.
Yeah. Okay.
And if it is bone involved, we have to separate the bone, and we have to preserve the neurovascular band also on the lateral side, sorry, on the sides of the both digits.
Okay. Just to change scenario for you, if it would have been a syndactyly of uh, first and second web space, second and third web space, then how will you proceed in that case?
First, we have to release the second web spacer, as it is important in more function for pinching.
Okay. No, I would go for third web space. Okay. Basically, the purpose is like if this is the hand, if this is the scenario for uh, syndactyly, then I would release this first so we can get 2 units. Okay, this 2 units, and this will function independently. This 3 units. Okay, and then I will release this one. Can you release this syndactyly in one session only?
No idea, sir.
No, can you release this syndactyly in one session? Can we go in one session only? Or should we do that or should not be done? No. We usually don't release simultaneous syndactylies in one go. Just for the reason that if we injure one of the neurovascular pedicle in this release, like in releasing this, if we injure one of the neurovascular pedicle, and in this release also, if we injure one of the neurovascular pedicle, then the middle finger will get compromised. Okay, so we cannot do simultaneous syndactylies in one go. Okay. Radiograph. Yes. Can you describe this radiograph?
So this is a CT 3D reconstruction of the skull.
Face. It's CT 3D reconstruction of the face.
With fracture in the infraorbital region.
Okay.
Extending up to the body of the maxilla.
Okay. So how will you proceed? What would be the symptoms of this patient?
There may be infraorbital numbness.
Okay.
And there may be, if the fracture is more displaced, there may be present of diplopia also.
Okay. Good.
And restriction of the eye movements if entrapment of the inferior rectus muscle.
Okay. And what would be your management in this case?
We have to do reduction of the fracture, and then we can go with the mini plate fixation.
Okay. Good. And what type of incision will you prefer in this case?
Intraoral incision we can first.
Okay. Any other incisions are you aware of? There are,
Subciliary incision.
yeah, subciliary incision is there. Any other? Initially, you told intraoral. Yeah. So there could be infraorbital incision also and transconjunctival incision also. Okay.
Okay.
Do you know anything about Medpore implants? It's credit question only, so just go through it. Go through the Medpore implants also for orbital rim, inferior orbital rim fractures. Okay. Okay, this is good enough. Okay. So it was good enough from all the candidates. If you are able to answer this much, then nothing to worry. This much answers are sufficient for you to give good enough marks. Okay. So just revise few things and go through the few topics. Okay. And don't worry, you all four of you have done good enough, and you will definitely do good enough in the exam also. Okay. So it was better on your part. Any other questions you would like to ask?
No, sir.
Yeah. Do you want to ask any questions?
No, sir.
Yeah. Okay. Dr. Lakshmi, Dr. Rakesh, Dr. Nagarjuna.
Sir, I want to ask one question to the candidates, where I have not received any information about the date and time of examination till now.
Sorry, I am not able to listen.
So the circular says the examination from 18th to 23rd, but
Okay.
no specific date has been provided, no date and time. So what can we assume, like?
Okay, then I will ask my team to just get back to you. They will confirm it with the authorities and they will let you know.
Okay, sir.
Okay. Any other part from the clinical point of view you want
Sir,
to
one
ask?
question, sir.
Yeah.
Sir, can theory paper questions can be asked in the interview also?
Sorry,
Like
with
theory part questions, and concepts.
okay.
Whether they have any marks of us with them. We had to revise it more of the theory questions.
No, theory questions you have to just go through the basic topics. Okay, so in this interview, it would be more of like your clinical knowledge and clinical skills. It won't be just about the theory. Okay, so if you are aware of basic theory, it is sufficient enough.
Okay.
Okay.
So, they will ask regarding extensor compartment, sir.
Yeah.
Extensor retinaculum, extensor compartment completely. Flexor and extensor.
Actually, just a second. I will show you the slide. So basically, I have given the list of few topics.
Okay, sir.
End surgery, the flexor zones and extensor zones. There are
Okay.
basically multiple zones in flexor and extensor tendon injuries. So
Okay.
you just go through that part also, and you are asking for extensor retinaculum.
Extensor zones, sir. Extensor zones, sir.
Yeah. You have to go through that part also. I have mentioned it in theory part also. So
Okay.
I've given this few list of few questions. These are the general questions. Just go through these topics.
Okay, sir.
This is the burns and hand surgery, and these are few aesthetic part, and this is few onco reconstruction part. Okay.
sir.
So you need to get overview of these topics. Okay.
Okay, sir.
It is not necessary that you go through this topic in depth, but you have to be clear with the overview of these topics. Okay.
Yes.
So I will share this with the Dr. Alesh. Okay.
Okay.
And he will provide you with this, or you can just send me hi on the WhatsApp, and I will send you this PPTs. Okay.
Okay.
You can note down my number
Yes, sir.
and send me the 94276
Yes, sir.
26
26.
444. Just send me hi on WhatsApp, and I will tell you in next 15-20 minutes.
Okay, sir. Okay, sir.
Okay. Okay, then all the best for your interviews. Okay. And be calm and focused. Okay. Don't worry, you will do better only. Okay. Okay. Thank you.
Thank
Thank
you.
you.
Thank you, sir.
Thank you,
Thank
sir.
you.